Hi, thanks for coming. I'm Torrie Fields. As I shared, I live in Portland, Oregon, the other Portland. Both are weird. That's been really cool to see. I'm going to talk a little bit later today about some of these new changes to palliative care benefits in the state. And I love that I get to have this conversation about how to implement with an interdisciplinary team first, because you kind of need different payment models in order to sustain a team. So this is the preamble to that talk. So I'm not a clinician. I'm a recovering actuary. And if you're anything like me, I had to look up what is an actuary before I interviewed for the job. And actuaries are just a fancy way of saying that we price healthcare services and determine what the value of services are for people. Before that, I was in public health and worked in health service implementation, like re-engineering big service lines in hospital systems to make them higher quality, more value-based, safer, et cetera. Have been spending the last 15 years or so in the palliative care space, largely from the insurance company side of the house, where I got an opportunity to start thinking about paying differently for palliative care for our members. And as I shared during Marion's talk, I'm a two-time cancer survivor, and I had the typical experience of cancer and oncology services where I wasn't dying enough for my own palliative care program. And so really passionate about the conversation about how you build a team associated with palliative care services and how we can leverage the workforce in a new and different way. So it's great to hear where you're working from, where you have a number of different service lines that you're using that has the opportunity to sort of contribute to the palliative care workforce. So going to walk through a couple of things today. First is when we say value-based palliative care, what does that actually mean? What does the literature say is the sort of right dose of a team? And then I'm going to go into some of the ways that you can actually prepare now, even if you're not getting paid differently right now, because there's a lot of like upfront cost to change into a value-based care model. And oftentimes what I find is that people wait for the payment to be different before they prepare for the future. And there are some ways to do it even under fee-for-service. And then my favorite topic is around data and information and documentation that your organizations can really think about doing to prepare for this longitudinal team-based palliative care approach to care. Since it's a small group of us, please just stop me or raise your hand and we can sort of dive into things if you have questions. So I hope this is more interactive than didactic, but it's kind of nice being in a classroom. So I'll share a little bit of what value-based palliative care services are, and I'll give you a couple of examples of those. Talk about the foundational elements of these services, and then how you might assess your own organizational capacity for to deliver value-based palliative care, and what might be some of the ways that you can help your project managers or people on your team who are actually developing plans to implement what MaineCare and I hope other health plans will be doing in the future. But let's just start with why. So as Marion said, there's a big difference between palliative care and hospice. And the thing that I really like to focus on is, why are we making any of this change at all? We know that people with serious illness need an extra layer of support. They need that support to be multidisciplinary, and it needs to be The same across settings. So there's been a lot of work, especially because of CAPC on the inpatient side for palliative care, where there's a better understanding of what team-based palliative care looks like in the hospital. Those same principles in the hospital can be transferred out into the community. So we shouldn't vary what we call palliative care by setting, because people need to receive the same thing every time, no matter where they are. There are certain things that we know that people need regardless of their geography. So urban and rural, we need it to be really equitable across geography, care setting, and then, as we heard Candace saying, across cultures. People with serious illness want whole person, holistic care. They want to feel like they're in control of their own experience and their own treatment plan. And they want to feel like people, which means it's not always medical. It's emotional or social or spiritual or cultural, and it needs to be at their level. So we can't just keep medicalizing people when we're delivering these services. And people are really focused on getting the right care at the right time in the right place for them. And we know that fee-for-service just doesn't let us do that. So when I think about brochures, as Marion was sharing, if I wanted to say what's the difference between palliative care and hospice, I feel like I would have to put all of the different benefits that are available to people, right? So we're talking about palliative care services, which is just one thing that people could get access to, right? So you have home health benefits that are available to people. You have hospice that's available to people. For individuals who are dually eligible or on Medicaid, they also have, they have health homes. They also have home and community-based services. And then you have, for kids, this concurrent care services benefit for children. So how do we make it so that palliative care is something that is a tool in the toolbox rather than something that seems like we need to compare it to all the others? It's really just a continuum of care. One thing that I find to be really difficult for palliative care teams is that if you look at the teams across all of these programs, they're very similar. They've got really similar features and elements. So I think that's actually why a lot of times we're inclined to say, oh, isn't palliative care hospice? Or try to explain it away to say, oh, palliative care is not like hospice, but it's got these similar features. You could say the same about home health. So if you're building out a service line or an organization or making that shift, you're going to have a bunch of different options for people and their families. And the difference is going to really be around treatment goals. So palliative care, from my perspective for interdisciplinary teams, the treatment goal is really around longitudinal care coordination. That is at the center. And to actually ensure that people are getting access to pain and symptom management alongside all of their other treatments and services they're receiving. So it's going to be an and. Yeah.
What struck me is that, I'm a hospice social worker, so one of the things that's hard for people to do is when they go over to their hospice Medicare benefit, they give up their regular Medicare. So if they're thinking they're giving up something by coming on board, it seems to be an obstacle. But how do you prevent that mindset when you're talking this way? And that it's true that if they hop onto palliative care, they no longer have access to others, or
extra layer of support here,
okay,
right? So if you think about it, we would anticipate that people who are receiving palliative care services, some of them may also receive home health. And some of them may also receive home and community-based services. And so then they've got a suite of things that's available to them. They could get respite, they could get personal care, they could also get help with rehabilitation for a fall, and they could get palliative care to manage the pain and other problems that come from their serious illness. Hospice is a benefit that also includes these palliative care services. So if somebody elects hospice, they're getting a bigger, broader, beefier version of palliative care.
Yep.
And so you don't necessarily need to have both when you're thinking about it that way. But a lot of times what I see is people conflating palliative care with concurrent care. And concurrent care is only available to individuals, including kids, that are hospice eligible. And palliative care is way upstream from that. It is when somebody is eligible for hospice, but they're still pursuing treatment. Usually it's in a sort of limited fashion, right?
Except for kids, they can get block nursing for home health.
Correct.
And get hospice. And they started considering, they tried to do that for adults at Fell Park. Well, there was a model and it worked, but not enough you know what. So
Right.
for adult, unfortunately, we thought we were going to get it.
But the eligibility criteria is still hospice eligibility criteria. And that's sort of the differentiating factor here, right? So if we think about what are the value-based palliative care services at a high level, this is an example from the state of Hawaii that actually just passed a budget amendment in their state to allow anybody who has Medicaid coverage to access palliative care services if they have a serious illness. This is a level deeper about, the messaging approach. So palliative care keeps the person at the center with an interdisciplinary care plan, and that care plan is in line with the person's goals for care. These services reflect the culture of the individual and are provided alongside all of the other benefits that are available to the person. So you don't have to opt out of anything in order to access it. There are three main features based on the literature of what team-based palliative care should include. The first is care plan development and implementation of that care plan, which means you're assessing the patient for their holistic needs and you're giving them a team and a treatment plan based on what their needs are. So there's some upfront work that needs to happen before somebody starts receiving longitudinal palliative care. And usually that starts with a comprehensive assessment. And you can't really do a comprehensive assessment unless you have a team. So I think somebody in the earlier session said, what happens when you go out there and do a hospice or a palliative care consult and then all of these needs arise? That's why team-based care is an important element of this. If you have somebody who has existential suffering, but you don't have a chaplain or spiritual care professional on your palliative care team, then, how are you going to address that? Who are you going to use? Like, what person on your team is going to address existential suffering? From a value-based care perspective, the clinical services need to be delivered through an interdisciplinary team based on that person's needs. And they need to address the pain and other problems that come from somebody's serious illness. So it doesn't necessarily have to replace a primary care provider or a specialist, but these are going to be individuals who can address what is arising from the treatment or from the illness itself. And just to say something about this 24/7 coverage, you don't always need to be there in person to be available 24/7, but anticipatory guidance is the name of the game with palliative care. So being able to understand what people's needs are and then anticipate what might happen if a problem arises, that's going to actually cut down the need for you to go out to a home or see somebody in person after hours. Yes.
When I talk about, I do a lot of anticipatory guide, but it does end up feeling, I think, to the final, that's very negative. Aaron, how do you how do you remain positive as you're anticipating their needs?
I'll give you an example from my own experience with palliative care a couple of years ago. My father-in-law had heart failure. And one of the things that they were struggling with was he was going to the emergency room in the middle of the night because of shortness of breath. And we started to really talk about what his labs were saying, that he was going based on what his lab said, he actually had his heart was enlarged and he was unable to really take as deep a breath as he expected or he was anticipating before. And so by helping them understand that you elevate the head, that you actually, this is something that is normal, you're going to actually not take as deep a breath as usual, actually made it a lot easier for my mother-in-law to address his needs in the middle of the night and to know what's the difference between an anxiety attack, normal course of disease, and something that needs to go to the emergency department. So things like that really help with patient education around what is happening in their body so that they know when to call in the middle of the night and they know what is normal.
The difference here is that empowers them. So it isn't negative, like, here are the 20 horrible things that you have to do. It is, here are the things to look for and what you can do about them.
And also, I think you were talking more about getting palliative care involved. Once palliative care is involved.
Exactly. So I'm talking about general, but you're talking about now a specific person with a specific set of illnesses, and that's a different conversation where we would talk about end-of-life.
Yeah, no, it's actually really important because when people are continuing to pursue treatment, they have side effects from treatment. And when people are earlier in their course of disease, they actually need more understanding about their course of disease. And so there's a lot of disease education or treatment education that is really what I'm talking about when I'm saying anticipatory guidance. Mm-hmm. To empower the caregiver in that situation actually, keeps people out of the hospital. And then the third part about this, which is the thing that I have seen be the biggest struggle, especially for hospice-based palliative care teams, is around care coordination and communication. So what's different between palliative care and hospice is that hospice is an all-inclusive benefit. So the hospice is delivering the medications and the durable medical equipment and the supplies. With palliative care, you have to coordinate those things. And that takes some different skills and some different planning. And sometimes you have to talk to an insurance company to get authorization for those things. And that's annoying, right? And so some of the ways that you might need to change your team around is to identify how to get the nurse or the social worker on your team the skills or the tools that they need to start doing more of this care coordination, which starts to optimize your team a little bit more. And it starts to develop like short lists of comfort items or short lists of durable medical equipment that you might just in advance need to ask that insurance company for. They're trying to do the right thing. They don't always know what it is. Believe me. So some foundational elements about from what we hear or what we have seen in return on investment analyses and the papers and studies that have come out about community palliative care. So for eligibility criteria, these can really, these can be used for adults and for children. What we are seeing from health plans and from other Medicaid agencies is this removal of prognosis from palliative care. So focusing on what is the condition, what are the diagnoses that we would consider are serious illnesses, and then the level of symptom burden or functional decline that people have. So if you're using the palliative performance score or the Karnofsky scale or ECOG or any of those things, those are going to be levels of symptom burden or function that can replace things like prognosis. So we in the past have talked a lot about like the surprise question. Would you be surprised if somebody died in the next year? I would argue that that's probably, if you're answering yes to that, you're already downstream. And somebody is a lot closer to hospice eligibility than you think. So starting to assess people, especially if you have a chronic care management program, assess people for their functional decline or their impact to activities of daily living is actually going to get you to move upstream on the palliative care side. Do they have a serious illness? What amount of needs do they have? Can a palliative care team address those needs in a more holistic way? You see the 3 sets of services that we talked about in the last slide. And then what we're seeing come together as the core staff are a physician, a nurse, including nurse practitioners who can extend physicians and do prescribing, a social worker. In Medicaid programs, oftentimes you see the need for a qualifying mental health professional. So that could be an LCSW versus an MSW. Some amount of spiritual care. So in Hawaii, they call that a grief counselor. That was CMS's terms, not ours. But somebody who can do the existential suffering, manage existential needs. And then child life specialists for pediatrics. One thing to note, as everybody tells me, there aren't enough child life specialists to go around. So one of the things to think about is, how do you create this core staff model when you have to share the finite resources that are palliative care providers? I usually find that social workers and child life specialists are the hardest ones to find. And it might be that you might need to share some of those individuals across organizations. Yeah.
And to that point, the main care model is not rolling out requiring a team that's enrolling to be 5 FTEs. It's building the program so that you're identifying those clinicians or those providers, but they could be sharing their time across several different models of care, so that there's not a barrier to beginning your program. And then, of course, once the panel grows, that may change, and you may have a full-time team, but to address that sharing of child life specialists, of social workers, and the barrier to beginning the program.
Mm-hmm. It's a great point. In Hawaii, there is only one health system that has child life specialists, and the benefit actually enables them to contract with all of the providers in all of the islands so that they can have a centralized hub of child life support. So I would imagine in rural areas like Maine, there might be some interesting centralization of certain staff members. This is sort of the core staffing that I would say is like the required members of the team. There are other ancillary members of a team that really should be consulted depending on a person's case. And if you have a prescriber, like an actual co-management model for palliative care as a core component, then I would imagine that some prescribers can handle most patients, or prescribers can handle most patients, and you may need a pharmacist for certain complex situations as either a peer consult or as somebody who comes in as an optional member of the team. So it really is just what is the most common group of people in order to get the results. We're not seeing some of the other like home care aid or LVN or other services that also might be really beneficial to add onto the team. Pharmacists can also bill independently, which is another feature. So if they're able to do some of that, you can bring them in to a model and help to consult the team. But what's really critical about the core team is that they actually attend the interdisciplinary team meetings, and they direct or oversee that plan of care as a team. And pharmacists may not need to be at every IDT. Always good to have one. Absolutely. Even when I was working at Blue Shield of California, I lucked out and we had somebody in our pharmacy department who came from Dana-Farber and was a palliative care pharmacist. And she made all of our palliative care teams' lives so much easier because you never got stuck in prior authorization land. She was just like, just get a solve for that. In terms of thinking about where the going knowledge base is on a reimbursement model for palliative care services, we're kind of in have feet in two canoes. I hear canoeing is a thing here, where there's fee for service and there's this promise of value-based payment. You can really start with a kernel of NP social worker if you're doing fee for service. Building a team around an NP social worker combination can really get you from here to there, from a fee for service to a value-based component. So while you're waiting for this wonderful woman to build out the benefit, starting to get your team centered around having an NP social worker combination is something that you can even start today, because those two can bill. As I shared, focusing on anticipating needs then sets you up for making sure that you're going to get the results that you want to get, and not having people going to the emergency room or the hospital. You can be the alternative. And when talking to insurance companies, as I said in the previous session, insurance companies have changed their flavor a little bit when they talk about cost savings. And what has worked really well in conversations with health plans is really focusing on reducing readmissions. Because a lot of times you find palliative care needs when somebody admits to the hospital, and we just want them to stay out of the hospital going forward when they can. So making sure that health insurance companies know that your value is in reducing readmissions goes a long way for those insurers to think about paying differently for that. And then improving quality is something that insurance companies do care about, and they often incentivize palliative care teams on the quality that they deliver. One of the things that I have found really interesting about things like the Enhancing Oncology model or the Medicare Care Choices model or any of those things that CMMI has put out is that they've been focusing a lot on quality measures that are end-of-life measures. Things like chemotherapy in the last 14 days of life or hospitalizations in the last 30 days of life. Those are indicators of quality for people who are hospice appropriate, but not always for palliative care appropriateness. And so thinking about how you can reduce no-show rates or reduce delays in care or any of those quality measures can actually go a lot longer on the reimbursement conversation. So documenting goals for care, looking at progress toward goals. The John A. Hartford Foundation funded a goal concordant care measure that is part of measuring what the age-friendly metrics. You can look at self-sufficiency or caregiver confidence. That's actually going to measure your level of anticipatory guidance. Understanding health during treatment. So for cancer patients, if they're staying on pathway or on their regimen, that's a really good selling point for oncology teams. And then making sure that you're really focused on preventing unnecessary or unwanted care rather than just saving money. So you don't want to take things away that people want. You want to take things away that people don't want. I would be remiss if I didn't bring up experience of care. So making sure that people feel heard and understood. Those are MIPS measures and macro measures that you can sign up for even under fee-for-service for Medicare. The biggest foundational element to look at when you have an interdisciplinary team, and the thing that I have seen as the most underdeveloped in value-based care, are staffing ratios. What's really important for actuaries like me and for reimbursement models that you want to see is knowing your patient to staff ratios and how those ratios vary by patient acuity. So if you have a palliative care team, you should start to build this out like a software program or like a pharmaceutical. Diane Meyer liked to say, if palliative care was a drug, we'd be making a lot of money. So you have to think about it like a dose. How many visits by discipline should somebody have? And how many patients can any individual clinician take on their panel? When you start to think about that, then you're able to be more responsive. You can actually advocate for yourself in a payment negotiations because you actually know your numbers. And that also allows you to develop interdisciplinary team pods that can be deployed geographically or can actually meet on a regular basis. So that if you're shifting from a fee-for-service to like a salary type model, monthly payment model, those are the elements that you need to start thinking about and documenting as part of your team. The other piece is that patients and families are going to need different levels of care based on their acuity or based on what you find. And so having some standardized policies and procedures around service minimums. So at minimum, we will have a nurse see the patient X times per month is going to be really valuable for you to create a floor for how often people should be seen in order to really feel engaged with the palliative care team. All right. So in terms of thinking about readiness, you're all operating palliative care under fee-for-service today. So there are 5 things to think about when you're shifting to a value-based payment model. One is what is the model? So what is the thing being required of me by the insurance company or by Main Care or by whomever is thinking about paying me? Those models may be different depending on if it's an oncology practice that's working with you or it's an insurance company that's working with you. And then you need to do some introspection. So what are my costs? What are my baseline? What's my baseline performance? And how does what I'm doing now differ from what I'm going to have to do in the future? That's going to tell you what your upfront costs are, what you actually need to invest in order to change. You need to know your customer and your market. So who are you going to be serving? If your population is a Medicaid population, they come with certain features like social determinants and financial insecurity and sometimes cultural or language barriers. And if you're talking to Humana, Medicare Advantage, you have somebody who has a little bit more affluence who can afford a Medicare Advantage plan and is going to be older. So think about who your population is that you're serving and what their underlying needs might be just based on who they are. So know your audience. And then in looking at your market, there are going to be different opportunities for scaling your services between urban and rural, where you have different team members, et cetera. So if you're in a rural environment like Maine, telemedicine might be something to invest in because you won't be able to drive from the south to the north efficiently in a day. We don't need, you're already a finite resource. We can't have you burn out. How do you have, this is what we've seen in Eastern Washington and in Montana, is a lot of that, expert guidance coming from like a centralized virtual team, and then training folks on the ground who can be your extenders for your services. And that approach is something that actually works. There's really good outcomes from those things. And you can't necessarily sustain those models without something like value-based payment, where you can sort of share the dollars between teams. I think that's the challenge, right? And why we've really wanted to advocate for telehealth type offerings.
This is one to a big question, but in the countries that have national health service, are there some of these issues in those too? Okay.
Yeah, I just spoke with some people actually in England. They have very ironically robust community
Mm-hmm.
and not as much hospital. But a lot of it's because the way their system is healthcare is a weird thing, socialized medicine, but also charity trust driven.
Mm-hmm.
And so it's a very interesting thing to start thinking about some models. We're the one country in the world that actually has a systematized home health program versus also a hospice. Many countries just don't have health services or home services at all. And so it makes it hard for us to kind of think about implement, because then you're looking at development in a different way.
Yeah.
A great question.
Curious, because, there's a part of me that sees the burden of all of this and orchestrating all of this, but didn't know if we're reinventing a crazy wheel here.
I think it's the challenge is that medical innovation has helped people live longer and have more access to treatment than ever before. And even in the early part of the 1900s, people were dying from infectious disease because we just didn't have vaccines or basic antibiotics. So now that people are living longer with serious illnesses, the whole system needs to change, and cancer becoming a chronic disease. I mean, that's a game changer right there. It means that these services are new to everyone because the innovations that keep people alive are new to everyone. I've had to give literally this exact same conversation to people in South Africa who are trying to also figure out how to get value-based payment for palliative care services. And they're, as Connie was saying, their hospice benefit is charity care, right? Palliative care is something that needs to be part of their medical system, part of medical delivery. So that's it. It's just life. Thanks pharmaceutical companies for doing your job, for keeping people alive longer, finding treatments to things.
But it's also cultural. You have socialized medicine. You're thinking about what is the common good for everyone. So you may not spend $3 million on medicine if in fact it's going to affect the other 200. We don't have a sense of community of good for the whole. It's pretty much what's in it. And that also changes when you have healthcare systems that, yes, you may have emergency rooms, but they would never be they wouldn't default to what we do. They would sort of be kind of doing regular care until they talk to someone. So, that also changes the whole.
Mm-hmm. But bringing things out of the hospital is really about how do you replicate that experience of a hospital-based team that's quite responsive in the community setting. So taking the facility out of it and just moving into that team-based approach or preventive approach to care. So from that angle, what something like value-based care can do is make is really help you develop a team structure where you know roles and responsibilities on your team. You're able to assess for current capabilities, and you can start to think about this not just being a doctor treating somebody, but a team delivering care. And so some of the things to really think about internally are, who do we have on the team today? What are their skills and competencies? What things do they need to learn in order to move or be shared by a hospice and move to something like palliative care, or be shared by a home health and deliver something like palliative care, because the intent to treat is very different between those different service lines. Oftentimes I have seen the need to really find different nurses if you're doing palliative, because there's so much hands-on clinical that happens in palliative care. And then know your numbers. So a lot of what we're talking about puts the accountability onto the palliative care team or to the provider to actually know the services you're providing in a little bit more granular detail. So make sure that you're starting to track how you're doing today. Identify what data you're actually collecting already, and how that differs from what you'll be expected to deliver or report to either the state or to the health plan partner that you have. And I know it's everyone's favorite topic to talk about electronic medical records, so I'm just gonna plug that here. You can get started with the current EMR that you have. However, the EMRs that are out there today are not palliative care centered, nor are they value-based care centered. And so some of the bigger challenges that I have seen are in assessments. So where are you going to document clinical assessments, especially if those things are done by a non-billing clinician on your team? You can start out with dot phrases. You can start out with your notes section and build some of those things out. But very quickly, you'll identify that you need some fields in your EMR. I am sorry. If only we could get Epic and Cerner to change.
So Epic and Cerner don't have any like plan of care or palliative care type. Are you kidding me? I didn't know that.
They do this, each Epic, every program has it. The problem is they don't share it.
Correct.
It's something you have to pay.
It's a buy-up.
Oh,
And everyone's reinventing the frame.
right.
Mm-hmm.
So it's not part of their off the shelf.
No.
It's that you subscribe to. It's
Their business model is to charge you for it.
yes.
And the problem also is that palliative care usually last on the list when people think about it. So then when you ask, we're like, oh, well, no, we've already done all that.
Or they say it'll take 2 years.
2 years. So it's really problematic.
Mm-hmm. The documentation piece is really, I would say, the hardest part of this. You can start on spreadsheet or in unstructured notes. You can start there, but that's where I think, just to share with you, where the clarity needs to be there for providers, so that it's when you actually do get your ticket called after 2 years of waiting, that you know exactly what you need to build. It's billing.
And so it's very frustrating, even if you build templates, you're billing it so that you're just exactly. Any of us who are clinicians, I don't think we feel wonderful on our notes, which then makes it ironic because we're trying to show what we do and bill at the same time. And bill at the same time. So it's very frustrating. And it's the right thing to do. I mean, I would say our program literally 6 years ago was still doing dictation notes, which was kind of fun. And now we're doing, and I'm like, maybe the dictation is better because we could really speak to what we were doing and that stuff that we wanted.
Yeah.
But that's a cost, actually.
It's a big cost.
Mm-hmm. Let's see. So some things to really think about. This is a roadmap. So for folks who like to project manage or work with project managers, There are certain phases to actually implementing change in an organization. The first is actually doing that internal work of where are we today? Where do we need to be going? And then the punchline at the bottom of this is a business case, because you as a provider are going to need to know how much it's going to cost you to move into a new model. That is something that's not going to be reimbursed by an insurance company. So you changing is a requirement of a contract. It's not something that gets paid for through value-based care. And so that's the upfront cost of just doing business. So that first piece of strategic planning is really getting down, where are we now versus where do we need to be? And what's the cost for that? Both financially and from a resource-based perspective. The next phase is really around what systems need to change inside of my organization to make sure we're compliant. So policies and procedures, patient enrollment processes, intake and referral processes, all of those things are really your process planning that need to happen. And I could never do any of the work I do without a project manager for a certain period of time who can help to execute on some of that change management. The third phase is around training. So your staff are going to be so steeped in fee-for-service that they have certain habits and they take care of patients using those certain habits. And so to change a model from fee-for-service transactional to relationship-driven longitudinal is actually a clinical change. This is something where your clinical team is going to need to train on a new model that's going to feel really similar to the model that they're doing. But that also means that it will take longer for them to change bad habits. I call that sick with fee-for-service. And you see it, there are interesting features of that all the time. So for example, nurses not going to an intake appointment because the doctor's going to do that one. Well, that is sick with fee-for-service. That means the doctor has been billing and now the team can bill. So the nurse can do a lot more than you think is the moral of that story.
They do a lot of documentation.
No, because fee-for-service driven mindsets are such that I need to go to that appointment. That is my patient and that is my plan of care. Right? And giving up that control is hard. It just is hard. So it takes a little while and it's just a shift. So staff training, not only on sort of back-end processes and documentation, but also in your clinical mindset. That's the thing to do even before you launch and start enrolling patients. So say if you're waiting for the contract to get signed before you train your team, you're going to see some bad habits starting out the first couple of months on your new contract. And then the last part of this is really around optimization and quality improvement. So this takes time to change. And so you can get started even if your IT structure is not fully baked or done. You can get started even if you have low enrollment or utilization. It's actually a good thing to start.
It's better to practice with fewer patients.
And even when you're still removing all the hands from your brochures, you can do one at a time and see and do the A/B testing, see how that works for you. And so what we have found is that these one-to-one relationships, really building out a good referral partnership with an initial partner and then adding another one, going slow to go fast is something that can actually work out for teams and can actually tackle some of the capacity issues that everyone perceives. But if you build it, they don't come is kind of good for your capacity constraints. Right?
But Torrie, you're saying with the approximate wiggle line. This is 180 days. That seems aggressive to me.
It's aggressive. It's aggressive. It's,
No.
oh, I'm saying it's a minimum.
Oh, God. Oh. Okay. I think for many people, this would be more like many months.
I have a program that we're in year 2 of this payer provider pilot for value-based palliative care. And we are on, like step 2 and 4 at the same time. And there's constant clinical training. But you want to give yourself at least 6 months of lead time to even start planning these things out. That punchline of the business case is going to drive your timeline. So how long do you need to stretch out the funding or the business plan? It could take 2 years, So in the next things, I'm just going to share some examples of what this looks like in other states for other programs. So on the eligibility criteria side, these are the conditions that are actually covered currently as part of the Hawaii benefit for adults and kids. What you see is that these are not stage specific or diagnosis code driven. These are condition categories, which actually puts more control onto the palliative care teams, but a lot more responsibility on your team to determine who actually should get your very finite resource, right? Because if you look at something like orthopedic disorders, I'm talking here about something like spina bifida for kids. I'm not talking about somebody who just had a hip replacement or has minor osteoporosis. So these are things that are going to mean that your job is to determine their level of need, right? And the things that are asterisks are pediatric conditions that don't have a good assessment tool to determine somebody's level of need. Does that look accurate to you? So what we did in Hawaii was we identified those condition categories that said you don't need a functional assessment in order to qualify for palliative care. There are a number of different assessment tools that you can put in your arsenal. And these are 3 slides. So the first are the clinical assessment tools that align with somebody's disease category. These should all be pretty familiar to all of you. And what we did was we actually identified the eligibility threshold or the cut point for community palliative care. So when you think about the PPS or the KPS for hospice eligible patients, you're looking at something more like 50. For community palliative care, you're looking at something more like 70. So people with moderate decline in function rather than people with who really need a lot of help. There are other things that if somebody's clinical status actually determines that they have a certain level of need. So we found this out in some of our heart failure work, that people who have evidence of comorbid conditions or people with certain clinical biomarkers actually are good candidates for palliative care services. These things are going to be difficult things to find in claims data. So this is something that you can do as a palliative care provider to assess somebody's level of need that might not come through an algorithm or this magical claims-based list that people seem to want. Insurance companies just don't know. I'm going to go through this last slide. You can also use other assessment tools like past hospitalizations, past ER visits, home health episodes, and durable medical equipment to really qualify people for your palliative care program. So if you have a home health service line as part of your suite of offerings, these are areas where you can likely co-enroll somebody in palliative care, or actually palliative care is more appropriate for them than being on home health. So those are some of the sort of tactics of thinking about how you use your current team and sort of move into palliative care. I have other slides, but now I'm being removed, so that's totally fine. You'll get the whole suite of these slides afterward, and my email address is on them. And so if you want to talk any more about interdisciplinary teams and how to really transform your team to take on this opportunity, please let me know. It was great. Thank you.